everybody. Welcome back. Another episode of ASAP Pathway of the podcast. I'm your host today, Dr. Stacy, and I'm really looking forward to the conversation today. Most people don't really dive deep into this topic, and I'm really happy that we're going to bring this to the forefront. I think a lot of people would like to know more about it. The topic of minimally invasive dentistry, cavities, aka caries, and how this all kind of connects and why it's important for everyone to have a better understanding of their options out there. Um, Dr. Douglas Young, Dr. Doug, he is our guest today, and he is an expert. And when I say expert, he is internationally known on this topic. And I'm so honored to have you today.
Thanks so much, Stacy. You're amazing too, as well.
Oh gosh, thanks. Thank you so much. I would love to do a quick bio. This is very abbreviated. He has a lot of publications and speaking and lectures, and but I want people to understand who you are, and I'd like to share that if that's okay for a minute.
Sure. I
Dr.
might
Young.
blush.
Oh, Young, you're gonna blush, Dr. Young. And then I'm going to call you Doug the rest of the podcast because we're just
I
going to
hope
get
so.
real. We're going to have a
I hope so.
conversation. Okay, Dr. Young. He is a renowned expert in minimally invasive dentistry and caryology. For those of you that don't understand, caryology is caries or cavities. Currently serving as professor emeritus at the University of Pacific, he is engaged in partnering with organizations interested in clinically implementing caries risk management strategies and minimally invasive dentistry, especially in underserved populations. As a founder of influential organizations like the Canberra Coalition, ADEA Caryology Section, and American Academy of Caryology, Dr. Young has significantly shaped the field of dentistry. So true. His contributions extend to the American Dental Association, where he served on the Council of Scientific Affairs from 2012 to 2016, and currently acts as a caryology consultant and member of the EBD, which stands for Evidence Based Dentistry Leaders Network. Dr. Young's international presence is evident through his global presentations, publications, and research on minimally invasive dentistry, silver fluoride, glass ionomer, and caries management by risk assessment. His work continues to drive progress and innovation in modern dental care. And this is so true. We've had you recently on the ASAP Pathway monthly members meeting. You did a webinar for us. It was amazing. I've learned so much. I actually went back to my practice and was talking to my associate about it. And we both were just like, why isn't this taught more? Why isn't this the norm in dental schools? And why aren't dentists coming out of school practicing this way? But I wanted to start with caryology, the study of dental cavities, maintaining healthy tooth structure, that precious enamel, right? We don't grow it back. How did you get started in this?
Gosh, that's a loaded question, but for the sake of time, let me just give you some background on my career. I started a scratch practice way back, and it took me several years to build that practice up. And I thought I was the hottest thing since sliced bread, doing all the continuing education. And then I come up with this continuing education course with John Featherstone, and he's a renowned expert in the field of caryology. And he basically taught me that I was not treating the disease of caries or cavities at all by just doing fillings, which is what every dental school in the country teaches us to do,
Right.
especially at that time when I started practice. So it started bothering me because why is our economic system rewarding us to drill teeth, which, as you know, starts a whole cycle of repair and re-replacement of those fillings. Those get bigger, they end up needing crowns, it gets more invasive, then a root canal, then you lose it, now you need an implant. So it's a never-ending process, but it's a no-win situation. So I kind of reassessed what my role was as a healthcare provider and said, you know what? I got into this business to be a doctor. I wanted to help people. I wanted to treat disease. I wanted to find the root cause of their problems and make them healthier. And that's what wasn't what I was doing in private practice. I was drilling, filling, and billing, trying to make an income to, you know, pay debt and whatever, make a living, raise a family. And it just didn't coincide. So I started learning more about cardiology. I got my master's from Dr. Featherstone. Um, and then, of course, once you know, how do you pretend you don't know?
Right.
So I, I had to spread the word. So I started, you know, in the education field part-time. And then another side note, dentists know this, um, the dental drill causes hearing loss. And my hearing loss dived down like a roller coaster. And so I thought it's best to phase out of private practice. And I really enjoyed teaching um, because nobody knew this at that time. We're talking 1995 area, and nobody knew this. Everybody was just drilling teeth. So it was exciting time for me. I started the full-time teaching at the University of the Pacific. I went to UCSF in San Francisco, but I taught at UOP in the same city, San Francisco, and actually stayed there 23 years as their cardiologist or person in charge of cavities. So, oh gosh, the timeline is blurred, but at that time, we started a coalition. That's why you mentioned the Canberra Coalition with the 5 dental schools in California because nobody was doing this. And in about 2003, the California Dental Association Journal really caught on board that this is the right thing to do. They started programs. We got grants for protecting, teaching pregnant mothers so that they get healthy children by preventing transmission of the disease. And so there's a lot of new things that were going on. We got reimbursement at our dental school for doing caries management by risk assessment. And we'll get into the details of all that later when you can ask me some more questions. But I just wanted to go over my background.
Yeah.
And so now, after 23 years, I'm focusing, hey, we've been teaching this for 23 years, and still the standard of care is to drill teeth because that's why we get paid. So I'm reaching out to organizations that are interested in implementing this now. I don't have time to wait for a new economic model to come out, such as value-based care, which is probably the way to go. Um, and we could talk about that later as well. But for right now, you know, underserved populations are really reaching out to me and saying, how can you help our population? Because we cannot drill our way out of this disease.
No. And okay, I would love to just for a second interrupt, if I may,
Oh, please.
because you keep saying this word, and I don't know that people understand this. And this is something I say to my team almost ad nauseum in huddles every morning when we are explaining decay to our patients. They think there's a hole, and a lot of patients just think, a lot of people think, oh, I have a hole in my tooth, like a hole in the wall, right? And I'll get to it next year, or I'll get to it. They think it's a stationary, they don't think it's dynamic, they don't think it's growing, they don't think it's a disease. You keep saying disease, caries, dental cavities. This is a disease in the I mean, in the population in general, but it's one of the leading diseases among children.
It's the
And
most prominent disease on the planet.
and it's transmissible. That's another thing people don't understand.
Well,
Like,
we have to be very careful. I wanted to butt in on that
yeah,
because,
because you mentioned how to minimize transmission. So, can we dive into that just a little bit, that topic?
well, let me clarify what I said because I have to be very careful because people like to dissect words.
Yeah, truth. Yeah.
Caries again, caries for the lay public means the disease process that causes damage to your teeth from a bacterial generated acid. And again, that damage could be going on and you can't even see it on the teeth. So it's like having, you know, diabetes, you don't know it. You don't wait till you have a diabetic ulcer and you need your foot amputated before you treat the disease. Doctors are paid to screen, identify the disease before it damages any other areas of your body, get you on medications or insulin, whatever, and prevent the problem from happening. So that's the whole model with the concept of caries disease treatment. You don't wait until there's a cavity. So when I said it's the most prevalent disease in the world, it is. And the transmission is from caregiver to child, but
Yes.
the disease is not transmissible. It
Correct.
is it is
Correct.
not a communicable, it doesn't satisfy the requirement for a communicable disease. But the bacteria that cause the disease
Mhm.
is transmissible. So pretend you have a cold, right? Those cold germs, bugs, can be transmitted from one person to another. Whether the person receiving the germ actually gets the symptoms of a cold is up to that person's immune system, their genetics, their local, in this case, local bacteria and chemistry going on in their mouth. So depending on how their caries balance is set up in their body, they may or may not exhibit signs of the disease. But it's something that dentists don't do because they just look at teeth.
Yes,
And
I try to have conversations with, because I see, you know, I always say womb to tomb in my practice. I see all ages, but when I'm having these conversations with moms, I have seen women just like pick up binkies or pacifiers that drop or whatever out of a bag, and they'll put it in their mouth to clean it off, if you will. Stick it right in their baby's mouth.
or test the food to see if it's too hot to go in the
Yes.
baby's mouth.
Yes. And then they put it right. And I'm thinking, wow, you know, it's one thing if they don't have you're transmitting that bacteria that can lead to, dental caries.
And then
Um,
there's also sibling to sibling or horizontal transmission
yeah.
from, you know, brothers and sisters sharing their soda pop or whatever. Um, but that's not the focus of the problem. It's just one part
One
of the
piece.
problem
It's a
is the
piece.
bacteria. And there's a whole topic on how do we, it's like gut bacteria, right? How do you establish a healthy flora in your gut? How do you establish a healthy flora in the mouth? Because we need our bacteria in our mouth. So it's a whole another topic about how to manage biofilm and bacteria so that it promotes a healthy environment in the mouth. And then
That's
there's,
a huge growing topic too. I think now more than ever, people are more open to discussing biomes, microbiomes, gut health. I mean, the mouth is the entry point um, to all of that, and it's interesting how um, when I was in dental school, I remember they told me my first year that I would see an end to the disease of dental caries by the end of my career. And I'm like, I'm 50 and I don't see an end in sight.
well, here's the thing that's going to make the public mad. Yeah, we have that knowledge now to prevent. This is a totally 100% preventable disease. We have the knowledge and the chemistry to do it now. And our model is broken.
Mhm.
And I spoke to your group. I was so impressed with your group because, and that's a whole nother story, is I'm so interested in airway and sleep dentistry because I have problems myself that I've went through and corrected using a lot of your techniques that your group does. So uh, I'm so, blown away by how oral systemic health has gone that far. And then you have the same problems that we do. The average general dentist is not an airway dentist, and shouldn't everybody have the knowledge to care for our patients to make them healthier? So to
Comprehensively, yes. Like, why
yeah,
aren't we discussing what's above the mouth, behind the mouth, below the mouth? I mean, there's a surrounding human being to this mouth, and we're something you said earlier really struck me too. You said, you know what, I'm just going to do this. I am not waiting for, you know, you mentioned value-based care, and you said, look, I'm doing this the way I think I need to do this. And that's what we've done too. And I think really going to the public, educating the public as to what is available to them, which is what I hope happens with this podcast, is to raise awareness on what you're going to teach us today, in our conversation, that they need to demand it. So when the public,
Stacy, some
yes,
of our patients are so knowledgeable. They do their own research. I mean, AI, look at the new iPhones coming out with AI and stuff. They know more about the stuff than I do sometimes. So it's amazing. And they get so upset. You mentioned you have children. I don't know how old your children are, but let's say you're a new parent. I'd be so upset if my dentist or healthcare provider didn't share with me my options for preventing a disease in my children, right?
yes,
Well, I mean,
right,
you know, we take it as normal because that's what we weren't taught in school, or that's not what we get paid for. But there's a moral and ethical thing here. And if patients knew that dentists or, there's ways to treat and prevent this disease, and I'm not giving the option to do it, I'd go find another doctor, right?
yes. 100%. And that's so on that point. So we were hearing how you went down this path. You started down this path. What are what are some things that can empower people listening today? What are things that you want them to understand about the disease and how it can be, basically you can intervene and just wipe this disease out of your family?
You know, I spent 23 years trying to teach people the science of this problem. And the easiest way I found to do this, and people laugh at me all the time because I repeat it all the time, is the cookie recipe. If I asked you, Stacy, what 5 things would you put in a bowl to mix to make a chocolate chip cookie? I bet you can come up with 5 things. Can you do that?
Ah, gosh darn it. I do prepackaged cookies, Doug. But I think flour, sugar, eggs, chocolate chips. I don't know what else. What else would I
That's
put in
fine.
there? Okay.
Baking soda, whatever, right? If you mix those things in a bowl, you make a little ball, you put it in the flatten it, you put it in the oven, 350, 15 minutes later at 350 degrees, you open the door of your oven. What are you going to see
You're gonna
100% of the time? I didn't
cookie
say taste good, but what's it going to look like? If
after baking it. I mean, it's gonna look like a cookie.
it's going to look like a cookie, right?
Yeah, you're
Okay.
gonna have a
Now,
cookie.
okay. So for a person to get a cavity, there's 5 things, and I call them the 5 ingredients for remineralization. Remineralization, for people that don't know, is the disease process of caries or cavities, is caused by bacterial acids that dissolve the subsurface of the teeth, and calcium and phosphate comes off the teeth and into saliva, and that's how a cavity starts to form. You're losing mineral. just like osteoporosis, you're losing bone. And at some point in time, the tooth gets so demineralized, it actually starts to dissolve the subsurface. And just like walking on thin ice, that thin layer on the top will actually cavitate, which means a hole, and that's how you get a cavity. Okay, so what are the 5 ingredients to make that repair itself? Because the chemistry is 100% reversible. So if I just reverse the chemical equation of acid dissolving a tooth, that's called demineralization. We could actually reverse that chemically and have it remineralize the tooth. And you see that a lot now on TV commercials with toothpaste
Mm-hmm.
that remineralize, bring back the tooth structure. So the 5 ingredients of remineralization are the opposite of what comes off. So calcium, phosphate, fluoride will help and make it more rapid and make it a more stronger surface, but it's not required for remineralization. That's something we can talk about later when we talk about people not wanting fluoride.
Correct.
So far I said calcium phosphate fluoride. The chemical reaction won't work unless the pH, the acidity in the mouth, has been removed. So pH is important. And then finally, the fifth ingredient is modifying the biofilm so that your mouth has healthy bacteria instead of acid-producing bacteria. So instead of getting into complete science, I said, this is a guaranteed recipe. If you follow the recipe, you won't get a cavity. Calcium phosphate fluoride, pH, and biofilm modification. So the next thing to do is, okay, what does a healthcare provider do to determine what ingredients of the recipe is missing on your patient? That's called a caries risk assessment. And you can come up with all these confusing questions about, because there's many different risk
Yeah.
assessment forms. But if you rethink what those questions are trying to get to, I want to know, what do I add in the bowl so that you don't get another cavity, right? So I rethink each question to determine, okay, what information about the chemistry is that going to give me? And then that becomes my treatment plan. If the patient is, let's say, lacking saliva from airway, from mouth breathing, from a CPAP, then they're going to require 3 things in addition in the bowl. They're going to need pH neutralization because they don't have enough saliva to neutralize acid. They're going to need probably a supplemental source of calcium and phosphate because calcium and phosphate comes from saliva, and that should help that patient. So the next question is, well, if they don't have it in their saliva, how are they going to get it? Do you take a pill? No. You look for dental products that have the ingredients that you need, and it works topically. You don't swallow it. It works topically. It diffuses into the tooth. And that's a whole nother topic I hope we can talk about later is how do we teach people about products so that they get the right things?
Yes. Also, we have a huge, I mean, this is my nemesis every day in the adult population is xerostomia with all the medications is one of the biggest side effects of meds is xerostomia, which is dry mouth. And they don't have their own saliva flow. So if we could also get people to produce more of their own saliva that contains the calcium and the phosphate, I mean, do you have any recommendations for that in a way that fits into that recipe of 5 ingredients? How we
Yeah,
can,
and it's so simple. You can boil it down to, you know, the mouth is a test tube, right? And the saliva is the fluid inside the test tube. And everybody's mouth is going to have a different chemical makeup. And so saliva or dry mouth is so important, and how many of the healthcare providers actually assess the saliva, how many assess the bacterial component or the activity of the biofilm to create acid. So if there's two mistakes in our profession, and I only had two things to pick, the two mistakes are we fail in our examination of our patients to assess saliva, and we fail to assess the bacterial component or the biofilm behavior of the patient's mouth. And those determine the chemistry in that test tube. So even the layperson can understand. Um, I mentioned your area of sleep, airway, dentistry. There's, something simple as mouth breathing can dry up the mouth and change the pH of the mouth. It prevents the saliva from diffusing into the tooth, and you are extreme risk for getting a cavity, right? Another example you gave was, I forgot what you said, but it could be something simple as, okay, I have healthy saliva, but I'm not drinking enough water. Fluid intake versus fluid loss, right?
Mm.
If you're a marathon runner and you're not getting hydrated, what's the first thing to go? Your saliva,
Yeah,
right?
dry mouth. I'm thirsty. I'm dehydrated. That's a sign for us to go get some more water.
And then
Um,
there's systemic diseases, HIV, diabetes, all these things that reduce saliva. And then there's, you know, habits that the patients have. Do I drink coffee with caffeine, Coca-Cola, where, it's caffeine is a potent diuretic. If you're peeing out too much fluid and you're not drinking enough water, there again, your saliva gets low. So the common thing is, we got to start rethinking each patient and their chemistry problems in the mouth, and we got to ask the right questions.
Something I had mentioned earlier was xerostomia. Is that what you were talking about? What I had
Yeah,
mentioned? Yeah.
xerostomia, for people that don't know, is the symptoms of having a dry mouth. Okay, and it's when the saliva, you actually can't call it hyposalivation until you measure it, but um, that's too complicated. If your mouth feels dry, assume that your saliva needs help. Okay, it's not a you don't need a PhD. If your mouth
Okay.
feels dry, then your saliva needs some help.
So I've had patients this last week who they have a water bottle in their hand while they're in the chair. They're constantly swigging before I laid them back. And of course, that's a flag to me, like what's going on. And they feel like, but I'm drinking water and they feel that replaces the saliva. So then I go into a discussion of the contents of saliva and how drinking water is wonderful and you need to keep drinking that water. Like you said, water in, water out, if you want to produce more saliva, but you also have a medication that's kind of fighting against this, and the importance of saliva. I have told patients over the years, like sugar free candies, things like that, are kind of like a workout for your salivary glands, really tart, but sugar free candies, maybe even xylitol based, things like that. What would you recommend? Also, talking to your primary care, can we switch up some of the medications so we're not having such a dry mouth? Or there are some medications that are helping with xerostomia and helping with saliva production. And I had a patient this last week. She was just recently put on a medication to produce saliva, and it has changed her life. Like people with dry mouth, it is debilitating. I mean, and their mouths, like we're talking tens of thousands of dollars of damage. That's the fiscal side of it, but it is destroying. I mean, that precious tooth structure, you can't get it back. There's nothing like your own tooth. So what are
Stacy,
you know,
yeah, Stacy, you made me remember problems that I'm having with myself with my airway. I in my past I was heavier. I lost 40 pounds, but in the past I was did a sleep test and I got diagnosed, of course, with sleep apnea. I started a CPAP and I thought that was the answer because that's what the doctor said I had to do. And that caused me to get a dry mouth at night. And Stacy, if you never had a dry mouth or
Mm,
people that are listening today, like you said, the dry mouth is the worst thing you could ever imagine. You wake up, your throat is so raw you can't swallow. Your tongue is stuck to your cheek. It's just terrible. You need products that can help lubricate all that and produce um, an environment where you could get back to sleep. And so I think you mentioned xylitol products and stuff. It's it's also about the correct pH. You have to, xylitol will not correct the pH. It won't provide calcium and phosphate. So maybe later we could talk about products about how to provide the chemistry. But I'm trying to open up the people's minds, whether you're a patient or a healthcare provider, a hygienist, an assistant, front office, I don't care. It's our job to help people understand we got to look at things differently um, because just by doing simple things, get to the root cause. If it's that CPAP, how do I get rid of the CPAP? Because it's causing me to have a dry mouth. So again, you start digging deeper at the root cause of the disease. For me, I was not breathing through my nose.
nose.
So, so I had to do a septoplasty with turbinate reduction. I wish I had that done when I was 12 years old. People
Isn't
told me,
that
oh,
crazy? Yes, yes.
people told me, oh, it's your hay fever. Buck it up. Learn to live with it. Nothing you can do about it. Oh my God. When I had the procedure done, a day later, I'm going, is this what normal people
Mm.
breathe like? It's incredible.
That's what
And
I
then,
try to explain to patients when they're on the fence about going to the ear, nose, throat specialist. I'm like, look, if you are breathing through your mouth, you have no idea the life that awaits you. Like, it really is when you can start breathing through your nose, which is the right hole to breathe through on so many levels physiologically. The mouth has zero physiological function for breathing, and the nose has like over 40 functions for breathing. So, and just from the comfort standpoint, but there's also, the physiology of nose breathing that's so important for our overall health. But um, this started for you at 12. So I mean, I could go down that whole topic of nose breathing, mouth breathing, but I want to stay on track because this topic is huge. Um, and I want to get to the
but
products
it
because
all connects to the cavity problem,
it
is
does.
my point.
It does.
The,
This all circles back to comprehensively evaluating our patients. There should be a saliva flow, there should be a pH, there should be, like you said, the correct biofilm, microbiome. Um, and we're not having those discussions. Just like medical school, dental school is very reactive. How do we fix things, treat things, not necessarily how do we prevent things? And we might touch on it a little bit, but not enough. And so, I have friends that I've had on the podcast recently, and they're like, look, med school, dental school it's very good at pharmaceuticals. It's very good at the mechanics. It's very good at how do we fix, repair, but not how do we prevent. And that's what
so
we need to
Stacy, let
do.
me butt in and ask you a question. I don't want to put
Oh,
you in particular on the spot, but let's say you're a dentist or a hygienist or whatever, and your office isn't doing this. Um, what's stopping you? It's the money, right? How do I get paid for this?
yeah,
Or
it's a
what's your
good
answer
valid.
to
That's
that?
very valid because if you cannot profit in a business helping somebody, then you can't help because the business doesn't stay open. So, how do you make the business of prevention profitable? How do you make the business of, getting ahead of something profitable so that you can help more people. I mean, people sometimes will look at doctors, physicians, dentists, and say, you're money hungry, you're this, you're that. It's all about the money. Well, okay. I can promise you 99% of physicians, dentists, we really love our patients. We really want to help. We really are people that are compassionate and want to help our communities. But at the end of the day, if we cannot pay the team, pay the staff, and raise our own families, right? And take care of our families, we shut down and then we're not helping you. So we do have to make money in order to keep the doors open. So your
So
point
let's role play for a minute. Let
is,
me pin you down. Let's say you're not
yeah,
doing it in a practice because you're not getting
all right,
paid. Your hygienist only has an hour to do her debridement.
right.
How can she spend another 15 minutes on Carrie's risk assessment? So what do you do in as a business owner? What are you going to do?
Right. So you either start for us, like our team, if they want more time, we're like, okay, we have to either raise our fee or we're going to have to, work out how on the back end, what's going out, what's coming in. I mean, we're
What
analyzing our numbers all the time.
Okay, but why did you as a business owner have to deliver something for free? My point is, how many people approach the patient and say, look, I know your insurance doesn't cover everything. We don't have insurance for groceries. I mean,
Right.
would you like an option to treat and prevent your disease? It's not very expensive. The products are what, $25, $30 or, you know, whatever. And lay that out for your patient and let them choose. Because you know what? I've changed doctors several times because they would not treat me medically the way I know I wanted to be
Mhm.
treated. So dentistry should be no different. You know, if your dentist isn't doing this, find one that's going to do it,
And
right?
I love what you said. Give the patient the option. I mean, and we do that a lot. I mean, it's like, we have this option of, testing your bacteria, figuring out what bugs are we looking at here with your periodontal disease. Some people are like, I don't want to pay for that. Okay, well, if you don't want to pay for that, we're kind of just doing the same thing over and over again and hoping for a different result. I'm kind of in the dark here if I don't know the specific bacteria we're dealing with, which is a whole other discussion on the periodontal bugs and the relationship with cardiology and different things like that. I mean, it's so connected, Doug. It's all
It
so connected.
it's so funny. It's so funny the way you put it because it reminds me of me. I am notorious for people trying to sell me something. I shut down right away. So if I go to the tire store and I just want some air in my tire, don't tell me about my brakes. Don't tell me about my shocks. My alignment could be out. And you know what? I'm so stupid. They could be right. I could be saving a whole bunch of money by correcting these things early. And I'm shut off because I think you're trying to sell me something.
I think that's a lot of people when they walk in, though, Doug.
So, but that's about us because how many of us are trained in motivational interviewing, finding out what patients value, and then listening to our patients and delivering to them what they want. And I tell you, when I start using those techniques, very few people come up and say, yeah, I want to keep the disease. I'm not interested in preventing it. Because in the deep down inside, everybody wants to be healthier. So you got to listen to your patient once they elicit what they want. Our roles as physicians of the mouth should be to deliver on what that patient wants,
It's
not to
so
just
true.
tell them what to do.
That's
Because
so
telling
true.
them what to do does not, it doesn't work.
No, because the psychology, like you just explained, I mean, what we do emotionally and psychologically when someone is telling us, okay, you need this in addition, you came in for this, and now I'm explaining this, which happens to me all the time with airway. well, I came in, I just want a cleaning. Well, I've never met you before. I don't know what type of cleaning. I haven't even, I haven't even looked in your mouth. But they, and I think unfortunately, dentistry has created this itself, right? It's like a menu. They think they can come in, I want this, but I don't want that, and I want this. And then I'm like, you don't walk into your cardiologist and say, you know what, can you just do you know, just do that artery, leave this artery alone because I can't afford it. Like, I only want one bypass, not two by. I mean, we don't talk, but for some reason in dentistry, we've created a culture where people feel like it's, you know, Burger King and you come in and you have it your way and it's like a little menu of sorts. And it's like, wow, we've got to really change how we're talking to the patient, like you said, and what does the patient want? Maybe we aren't the right fit for the patient. If we're wanting to provide this type of care and we communicate that well and the patient still doesn't want it, that's okay. Maybe we're just not the practice for them. And that's
And you
okay.
hit that's hitting the nail on the head. And it takes the whole team to do that, from front office to every single person of the team needs to elicit this type of mentality that to their patient, that you're in a special practice here. Not everybody is going to work at making you healthier. This is where I bring my children. I would not go anywhere else. And once patients realize they're in a special place and that you're not making money per se, making them healthier, but you care about them, they
Mm.
they start looking at it differently. And here's the deal. Once you teach them they are getting healthier, they go, this is the first time in my whole life that I haven't gotten cavities. You guys are special. I'll never go anywhere else. So um, there's a few tools that I want to talk to you about on how that can be incorporated into the office.
Well, I mean, I want to hit on so many topics. I might even have a part two with you, Doug, because I feel like there's so much to say and I'm not getting to all the points. I want people to walk away. Here's what I love. I would love people to hear this today and say, you know what? What if at our next team meeting we listen to this podcast as an office? Or what if I, as a patient, share this with my dentist and say, hey, I love you as my dentist, but can you start treating my family this way? How can the dentist learn more? So patients demanding the care, a lot of dentists don't even know it exists because it's not taught in most dental schools, right? We would love for this to be the norm, but it's not. So maybe, patients can take this to their practitioners. But here's what I would love to hit on a few things that you've said today. Like, um, how can you wanted to discuss some of the products. But first, I wanted to back up. You mentioned Carrie's risk assessment. So, how do other dentists, other oral health care providers get a hold of this Carrie's risk assessment that you feel has been kind of simplified that can look at the risk assessment? Because then once you do that, then you can say, okay, now how do I fix this problem? Products, training, implementation. So I'd like to hit on the Carrie's risk assessment. Is there a place they can get that?
Yeah, Stacy, Carrie's risk assessment is taught in every single dental school in the country. By now, every dentist and hygienist knows what a Carrie's risk assessment is. What form you use, to me, is not as important if, as doing it and using the concept of the 5 ingredients, right? When you
That's the key. I don't think that that's how it's being looked at by most. I mean, we do ask our patients, "What's your diet like?" And you look at Carrie's risk assessment in certain ways, but I love your perspective of the 5 ingredients. I just didn't know if there was a simplified or more, um, if you've created something a little differently.
yeah, I actually have. I've worked with Dr. Featherstone's research group for a long time, and we've published in the CDA journal um, a validated Carrie's risk assessment form. Validated meaning there's been several outcome studies looking on does it correlate to, does the question correlate to what it's asking? And so most risk assessment forms are not validated. I'm not saying this form is better than another, but we published it several times in the CDA journal, and people started calling it the Canberra risk assessment. Canberra stands for Caries Management by Risk Assessment. So when people say the Canberra form, that's the one that was published several times in the California Dental Association journal. Recently, when I started working with underserved populations, it was too complicated because that form doesn't tell you how to use the form. So what I did was create a form using the same questions in a column format. And I posted it on my website. The problem is we're in the process of publishing that form.
Okay.
So I don't have a problem you using it in your office, but please don't lecture with it or let it out to the public because we're going to publish the form. Um, Perhaps you can give my website and it's under resources, um, and it's the Caries Risk Assessment form.
And your
Um,
website is Dr. Doug Young, Dr. Doug, Doug Young, Young.com. I know it's a work in progress, you said. So um, if people go there, they can get some information and start the journey. I have to have you for a part two. And because I think there's just so much to talk about. I mean, you think, oh, we're going to talk about cavities today, everybody. I mean,
so
and
simple, right?
it's so simple, right? No, it's wow, it's such a complex, really a health crisis, really. And the profession that is supposed to be, the superheroes handling this, we aren't. And nobody else is. If the dental profession isn't going to handle this, nobody else is. So we have to um, get our acts together and really focus on prevention. I think the microbiome research is going to be huge. I think getting that under control, and I think everybody's more open to that now more than ever. So I'm hopeful, Doug, that this is really going to take off. How can people, I know you're speaking, you just recently retired from full-time education and now you're consulting and you're speaking. So I know that you have an email. You said I could give out your email if people want to have you speak, bring you into their communities, hire you as a consultant, if you will. Your email is D as in dog, or D as in Doug, D Young at pacific.edu. Is that correct?
That's correct.
And I'm going to
And
put those in the link in the podcast too.
okay, and since you mentioned my website, let me kind of explain how to use that. Um, that website was set up for me to do to post my lectures and to have people pay a small fee to review them if you haven't heard me speak. But it's not functioning, I don't think yet. So use that as a menu of what I can talk on, and then contact me on my email, and I'd be happy to come out to your organization and do some training because we haven't even broached the topic of minimally invasive dentistry, silver
Nope.
diamond fluoride,
Nope.
glass
We're doing a
ionomer,
part two, Doug. We have to
the
do a part
clinical
two.
part.
I do want to touch on, if we could, as
Oh, one more
thinking,
thing.
go ahead,
On
Doug.
the on that website, if you want to get to the free download stuff, you have to go to the resource tab and then navigate what you want to download. Um, so just keep in mind it's not a
Good to know.
100% functional website, but
It's a
it's a
work in
start.
progress. Yes. And so on those topics, can you in less than a minute, somebody that is on the fence, because I want to get into products a little bit here, so somebody can leave today and just at least have a place to go to research products, look at products. How do they find a dentist that thinks this way? And But the fluoride, okay, that's a hot topic. It's controversial. I get it every day. Some people were, nope, we're a no fluoride family. How do you convince someone that is against using fluoride for health reasons? They're concerned about the toxicity, correct? And I understand that, and they're wanting to really take care of their family. But silver fluoride, um, how would you get them to, in just a couple minutes, if we could, just be open to it? Where can they go to learn more about it, to be a little more open to it, and the amazing things it's doing?
You're asking the question, where can patients go to learn more about it? Or,
Where anybody can go. Yeah, patients, like, let's say a patient's listening and they're like, I'm not using fluoride. Nobody's getting near me or my family with fluoride.
okay,
What?
are we allowed to mention companies?
Yeah,
Okay, because as a speaker, we're not allowed to endorse products or mention companies unless it's, you diversely show everything or it's unique. So before this podcast is over, I want to just tell you um, what we're going to do is with that fluoride adverse patient is break away from old habits on trying to win the argument. We always tried to win the argument by presenting them with scientific literature
right.
showing that fluoride is not going to kill you, used at the right percentages. Instead, we use that motivational interviewing. We listen to what they're saying, and you might say, Mrs. Smith, I totally understand what you're saying. If I hear you correctly, you're really concerned about what you're reading about fluoride and how that might affect my small infant. I understand that. However, would you mind if I share with you my thoughts on fluoride for my own family? And most people will say yes. And then I go into it like fluoride only works when it's topical, which means inside the mouth. You don't have to swallow it for fluoride to work. And most dental products, including silver diamine fluoride, work topically. So we go to great lengths on how to give the right dose of fluoride so that you don't ingest it. And that usually takes away some of the adversity. But long story short, let's just pretend that patient is dead set against fluoride. Don't even go there, right?
Right.
The way I handle that is, okay, if I hear what you're saying, you don't want fluoride no matter what. No matter what you're
Right.
not interested in me sharing any information. I get that. Let's let you feel better. We can do this without using fluoride. The 5 ingredients includes fluoride, but it'll happen without it. You just have to work a little bit harder. And you're going to have to use your products more, you know, more throughout the day because this problem cannot be solved with one toothpaste. You're going to need to do several products during the day. Are you willing to go through that if we don't use fluoride? And most of those people will say, yeah. So what you really did was you stepped up their motivation. They get what they want and they're willing to work harder to do that. It's a win-win situation. So instead of fighting that person about fluoride, let's turn the table so that they're more motivated to using the products that will also provide health in the mouth.
At the end, the end result is we're working with that patient on their specific concerns for their family and their needs. And they have the right, and giving them that autonomy, and giving them options. It's all about options and listening to the patient. And sometimes we have to do a workaround. And if the patient's on the same page with us, that's fine. They might just have to do it a little differently. I love that. Um,
Oh, Stacy,
yeah,
one more thing. Going back to your question about where do patients go, I often refer patients directly to the companies that of the products that I use. Instead of being the middleman, Go to their website, learn about the product directly from the manufacturer's website. You can call them. Um,
Well, that's the perfect segue. That's where I was going to go. What would you tell, where do you tell them to go for more
okay.
information on these products?
Okay. So if I may mention a couple of companies without, you know, biasing everybody.
Right, right. Just
Uh,
options for them, different
okay.
companies they can go to, and they can figure out for themselves what company they want to work with.
Okay. So let me just talk to you from my heart and what I've been involved with. Um, I work with people that are going to give me solutions that I can use on my patient that work. Okay. And when I lecture, you can't say that and
Correct.
say, this is what I could say, this is what I use. But, you know, if I could share with everybody listening to this podcast, go do your homework yourself.
Mm-hmm.
But there's a couple of companies. You mentioned silver fluoride. Elevate Oral Care is a company that has their heart in the right place. They were first to bring in silver diamine fluoride into the US. The people there are wonderful. They'll provide information for you. They'll reach out. I mean, they're in it for the right reason. And the other company I use is the Carry-Free product line. The company is Oral Biotech. The reason they're unique, and I'm full disclosure, the CEO is one of my best friends, so I helped give him ideas on products. And both those companies sponsor a lot of my talks. So full disclosure there.
Yeah.
But from my heart, those two websites will be a game changer for your team and your patients. And the uniqueness about the Carry-Free product line is they don't put one ingredient in the cookie bowl and expect it to work. So let me go back to what most dentists do. They do a caries risk assessment, and then they give the patient fluoride. That's like putting flour and more flour in the bowl, mixing it up, putting it in the oven, opening the oven door and expecting to see a cookie when you only put flour in there.
Right.
That's
There's no cookie.
ridiculous,
There's no
right?
cookie.
So the Carry-Free product line is unique because it's the only company that incorporates in every product the pH component, there's xylitol, and then there's, if you need it, calcium phosphate and fluoride. So it has the 5 ingredients and a sixth one, which is xylitol. Um, but combined with the pH, that's the key. While I'm talking about that company, there's two things that I want to give you before we stop this podcast. And I mentioned them before. The two mistakes people are making are not looking at bacterial behavior and saliva.
Yes.
And to make it simple, and I'm just going to cut to the bottom line, one of the best tools to change people's behavior is a product that the Carry-Free company makes. It's called ATP bioluminescence. It's a swab that you take of a plaque sample, you put it in a little tiny meter, and it gives you a reading. And it's based on luminescence of acid-producing bacteria. So a high number above 1500 is like taking a blood pressure reading and saying, hey, you're 200 over 110, you got a problem. Okay, so that meter within, a minute, you could tell the patient, this is not conclusive, but it looks like your biofilm is highly acidic. It's creating a lot of acid. And that starts the conversation on, oh, what's bacteria got to do with acid and how do I fix that? So that is a game changer because right now we don't have a good metric to measure biofilm behavior. Sure, you can say, oh, you got a lot of plaque, you're going to need an
Right. But
antibacterial.
what's in right.
But this one is more quantitative.
Yes.
And when we can talk about it more time later, it's kind of cheating because I can guarantee you an improvement in those numbers. And the way I do it is I take a pre-op number on that patient and let's say it's high. Then I give them the carry-free treatment rinse, which we haven't talked about their products, but it has a 0.2% hypochlorite in it, which is 0.2% bleach. And so bleach kills everything, right? So I can guarantee that number come down because I've just made you rinse with bleach. Then I'm going to rinse your mouth out with water to get rid of all of the cheek cells because ATP is produced by living tissue. And then I take a post-op swab, and that number is going to drop in
Drop.
half.
Yep.
And I guarantee it well. So by doing that demonstration, I've taught my team that the meter works, the rinse works. So why don't we start doing it? And that one example will change the way patients view their products. And
Yes.
then the second thing is don't make saliva assessment so difficult. Look in the mouth, and if the saliva does not look like water, if it's bubbly, stringy, or dry,
Mm-hmm.
just assume they have a dry mouth.
Yep. 100%. And most patients, well, a lot of times I'll say to them too, do you feel like you have to drink a lot of water throughout the day? Because they their low saliva flow becomes such a norm for them sometimes that they don't even think about it. They just operate at that level. Like, oh my gosh, I do. I always have to have a Stanley or my thermos because I do feel like my mouth is dry. So having those conversations, Doug, we're going to have a part two called minimally invasive dentistry and go and do a deep dive because I got to stop um, for I know a lot of listeners are like they only can endure what are they you can only learn what the tush can endure or whatever. So
I know I'm burned out already. I
I
talk too much.
no, I love this. I love these conversations. They're so needed. And we'll have you back. You and I will come up with a time that works and we'll do a part two on this. I think it's needed. And I like I said, I hope there's an awareness raised. I hope people go back to their practitioners and say, hey, check out Dr. Doug Young. I want you to know what he knows because I really like coming to your practice, but I want this kind of care and I'm not getting that here necessarily. And in fairness to your dentist, it's listen, people, most dentists don't know about this. They haven't learned this. Partially they learn it, but like Dr. Young said, they don't know the full picture. They don't know all five ingredients, how to put the cookie together. We learn pieces, we learn to assess, but we don't learn how to implement the recipe to reverse, the process. We're not really taught that in school because we're putting out all these sugar fires all the time. So they're teaching us how to put out the fires, which we need to learn how to do, but we're not learning the other piece of it. Doug, before I let you go, I always like to say to people, if you want to learn more about ASAP and what's going on within ASAP pathway, we have a link to get a free newsletter. I'm going to have links on how to get to Dr. Young's website and how to email him to learn more. We'll do a part two, but I wanted to end with three questions for you. One, what did you want to be when you grew up, when you were little?
That's funny. I chose dentistry probably in high school, but this is a longer story, so let me give you the synopsis. My my dad gave me two choices, being Asian. You're going to be a doctor or you're going to be a lawyer. Which one do you want to be? And the background on that was he came poor from China. He was homeless at age 13. And I'll tell that story later. But the bottom line is he wanted a better life for me. And so now I understand why he was pressuring me to go to college, become a doctor or a lawyer. And so I chose dentistry. And I chose it because I wanted to help people. And I didn't want to work with dying people. I wanted to make people healthier. So I thought, and I love to work with my hands, so I chose dentistry.
Well, look what you're doing too. So we're I'm grateful that your dad pushed you to go to be a doctor because we're learning a lot from you. What is the last song you listened to?
Oh my goodness. I'm not a music person. I don't walk around with earbuds listening to music. Um,
Or even what's the last song you heard?
I can't even answer that. Oh, you
Okay,
stumped me.
I
You
know.
did you
Okay.
did good.
Okay, so if you're not a song person, what do you listen to?
I mean, I love music, don't get me wrong.
Okay.
I love music, but I can't even tell you. I can't even answer what the last song was. That's weird.
No, I love it because that's just an honest answer. You don't know what the last song was you listened to. Maybe you should go listen to some music
Hey,
after.
I grew up in Oakland, so I was like Motown,
Oh, okay. So you got a
James
genre?
Brown, James Brown, the whole thing.
Oh, yeah, love it. Okay, we got the holidays coming up. What is your favorite like dish or dessert at the holidays?
Oh gosh. My friends got me, for Thanksgiving, we've always done turkey, right? So I go over to my friend's house and he has ribs, right? So it it's kind of cool.
Yum.
Do
I
something
love
different.
ribs. Yeah, we started doing brisket because my stepdad, he really hates any kind of chicken or turkey. So I've been like, why don't we do some brisket? And I mean, I still have to have some turkey. I love turkey, but
So here's one for you. We with that same person, uh, we took our spouses to the IDR meeting in New Orleans. So we went on got all the best restaurants, and we took a cooking class. So tonight we're going to have gumbo.
ooh, I've never had gumbo.
Oh gosh, we
I
love
mean,
going to
I
New
hear it's
Orleans.
great. Oh, I hear it's so good there, especially. My gosh, what a place to get gumbo. If you're gonna have it in New Orleans.
Yeah,
Yeah, that sounds
take a
delicious.
cooking class.
All this stuff, all this cookie talk, and then ending on gumbo. I'm kind of hungry.
Follow the recipe.
I'm gonna follow the recipe, Doug. All right, we'll have you back. Thanks, friend, for being here. We appreciate your knowledge and your passion and helping to make the world a better place.
Thank you for inviting me. I mean, your heart's in the right place. I hope everyone understands that, hey, we can all get healthier.
Yes, we
We just
can.
have to advocate for it.
Agreed, friend. Thank you so much, Doug, and we'll see you back soon. Thanks for joining us, everybody.
All right. Bye, everybody.
Bye.